Liver cancer starts in the liver. To understand liver cancer, it helps to know something about how the normal liver looks and works. The liver is located in the upper right at the abdominal cavity and lies directly beneath the diaphragm. It is the largest granular organ, measuring approximately 20 centimeters in length, 15 centimeters in depth, and weighs around 1.5 kilograms for adults. The liver can be divided into two, a right lobe and a left lobe. Blood vessels and bile ducts also define the boundaries of 8 separate segments. The liver is the only internal organ capable of natural regeneration of lost tissue. As little as 25% of a liver can regenerate into a whole liver. One of its most important functions is to produce bile. This collects in bile capillaries within the liver. Some is stored in the gallbladder, where it can be discharged into the duodenum and small intestines to aid in digestion and break down fat. When the food is fully digested, the result in fat, sugar, protein, vitamins, minerals, and all other nutrition is absorbed into the bloodstream and transported to the liver for processing. Some nutrients, such as sugar, are retained by the liver and released if the body requires additional energy. The liver stores a multitude of substances including iron, copper, vitamin A, vitamin D, vitamin B12, and vitamin K. It also produces coagulation factors that are critical to cessation of blood loss from damaged vessels. Due to its wide range of functions, the liver is absolutely essential for sustaining life. Another important function of the liver is cleansing blood. Liver cells break down toxic and extraneous substances found in the blood and discharge them by means of excretion or urination. Because the liver is made up of different types of cells called hepatocytes, many types of tumors can form in the liver. Hepatic tumors may be malignant or benign. Liver cancer is classified as either primary, starting in the liver, or secondary, spreading to the liver from cancer in another part of the body. The place where cancer starts is called the primary site. Cancers that start in the liver are known as primary liver cancers or tumors. Primary liver tumors are usually associated with chronic liver disease, hepatitis B and C infections, and cirrhosis. Hepatocellular carcinoma, or HCC, is the most common type of primary liver cancer. It develops in the liver cells and damages other healthy liver cells. Continuous growth of cancerous hepatocytes can cause malignant or cancerous tumors to form. Other types of primary liver cancer include cholangiocellular carcinoma and combined hepatocellular and cholangiocellular carcinoma. If the cancer starts somewhere else then spreads to the liver, it is called secondary liver cancer. Metastases from other primary sites, particularly the digestive system, breast, and lung, are found in the liver 2.5 times more frequently than tumors due to primary liver cancers. While doctors do not know exactly what causes liver cancer, chronic liver infections such as viral hepatitis B and C, cirrhosis of the liver, and exposure to certain chemical toxins such as vinyl chloride and arsenic have been implicated as causes of liver cancer. Factors that increase the risk of liver cancer include A. Gender. This cancer is more common in men than women. B. Where you live. This cancer is much more common in countries in sub-Saharan Africa and Southeast Asia than in the United States. C. Ethnicity. In the United States, Asian Americans and Pacific Islanders have the highest rates of liver cancer. D. long-term infections with hepatitis B and or C. E. Cirrhosis. F. Heavy alcohol use. Consuming more than a moderate amount of alcohol daily over many years can lead into irreversible liver damage and increase your risk of liver cancer. Being obese. H. Type 2 diabetes. I. Certain inherited conditions such as hereditary hemochromatosis and Wilson's disease. J. Arsenic exposure, which can come from drinking water. K. Exposure to the solvent vinyl chloride. L. Exposure to alpha toxins. Alpha toxins are poisons produced by molds that grow in crops that are stored poorly. Crops such as corn and peanuts can become contaminated with alpha toxins, which can end up in foods made of these products. M. Using anabolic steroids. N. Tobacco use. Exposure to carcinogens and chronic liver infections are the main cause of liver cancer. Cancer occurs when liver cells develop changes or mutations in their DNA, which are the material that provides instructions for every chemical process in your body. DNA mutations cause changes in these instructions. As the damaged DNA is passed on to daughter cells, the DNA undergoes further changes and becomes unstable. Malignant transformation from normal epithelium eventually to invasive carcinoma. In its early stages, liver cancer does not produce many symptoms and is hard to detect. As the cancer grows, symptoms such as abdominal pain, which is a continuous dull ache in the upper right quadrant epigastrium or back, weight loss, general weakness and fatigue, anorexia, and anemia may occur. The liver may also be enlarged and irregular upon palpation. Jaundice is present only if the larger bile ducts are occluded by the pressure of malignant nodules in the hilum of the liver. Ascites develop if such nodules obstruct the portal veins or if tumor tissue is seated in the peritoneal cavity. Nausea and vomiting and white chalky stools may also occur. The American Joint Committee on Cancer TNM system, also known as the AJCC TNM system. This staging system is based on the results of the physical exam, imaging tests such as ultrasound, CT scan or MRI, and other tests. The TNM system for staging contains 3 key pieces of information. T describes the number and size of the primary tumor or tumors, measured in centimeters, and whether the cancer has grown into nearby blood vessels or organs. N describes the extent of spread to nearby regional lymph nodes. And M indicates whether the cancer has metastasized or spread to distant parts of the body. Numbers or letters that appear after T, N, and M provide more details about each of these factors. The numbers 0 through 4 indicate increasing severity. The letter X means cannot be assessed because the information is not available. T group. TX means primary tumor cannot be assessed. T0 means no evidence of primary tumor. T1 means a single tumor or any size that hasn't grown into blood vessels. T2 means either a single tumor of any size that has grown into blood vessels or more than one tumor but no tumor is larger than 5 centimeters, which is about 2 inches across. T3A means more than one tumor with at least one tumor larger than 5 centimeters across. T3B means at least one tumor of any size that has grown into a major branch of a large vein of the liver, or the portal or hepatic vein. T4 means the tumor of any size has grown into a nearby organ other than the gallbladder, or that the tumor is growing into the thin layer of tissue covering the liver, which is called the visceral peritoneum. Group. NX means regional or nearby lymph nodes cannot be assessed. N0 means the cancer has not spread to the regional lymph nodes. N1 means the cancer has spread to the regional lymph node. M Group. M0 means the cancer has not spread to the distant lymph nodes or other organs. M1 means the cancer has spread to distant lymph nodes or other organs. Liver cancer most often spreads to the lining of the belly or peritoneum, the lungs, and the bones. Stage grouping. Once the T, N, and M groups have been determined, they are then combined to give an overall stage, using Roman numerals from 1 to 4. Stage 1. T1, N0, and M0. There is a single tumor of any size that has not grown into any blood vessels. The cancer is not spread to nearby lymph nodes or distant sites. Stage 2. T2, N0, and M0. Either there is a single tumor of any size that has grown into blood vessels, or there are several tumors and all are 5 centimeters or 2 inches or less across. The cancer is not spread to nearby lymph nodes or distant sites. Stage 3A. T3A, N0, and M0. There is more than one tumor and at least one is larger than 5 centimeters or 2 inches across. The cancer is not spread to nearby lymph nodes or distant sites. Stage 3B. T3B, N0, and M0. At least one tumor is growing into a branch of a major vein of the liver or portal vein or hepatic vein. The cancer is not spread to nearby lymph nodes or distant sites. Stage 3C. T4, N0, and M0. A tumor is growing into a nearby organ other than the gallbladder, or a tumor has grown into the outer covering of the liver. The cancer is not spread to nearby lymph nodes or distant sites. Stage 4A. NET, N1, and M0. Tumors in the liver can be any size or number, and they may have grown into blood vessels or nearby organs. The cancer has spread to nearby lymph nodes but has not spread to distant sites. Stage 4B. NET, NEN, and M1. The cancer has spread to other parts of the body. Tumors can be any size or number and nearby lymph nodes that may or may not be involved. Management. Medical management. Radiation therapy. Radiation therapy is a treatment that uses high-energy rays to kill cancer cells or shrink tumors. External beam radiation aims radiation at the cancer from outside the body. Liver cancer cells can be killed by radiation. However, this treatment can't be used at very high doses because it kills normal liver tissue too. Having the treatment is painless. Each treatment lasts only a few minutes. Although the setup time, getting you into place for treatment, usually takes longer. Most often, radiation treatments are given 5 days a week for several weeks. Embolization therapy. Embolization of tumor vessels with chemotherapy is a process known as transarterial chemoembolization, or TACE. This produces anoxic necrosis with high concentrations of trapped chemotherapeutic agents. Chemoembolization is a type of chemotherapy treatment that supplies strong anti-cancer drugs directly to the liver. During the procedure, chemotherapy drugs are injected into the hepatic artery, the artery from which liver cancers derive their blood supply, and after which the artery is blocked. This serves to cut blood flow to the cancer cells and to deliver chemotherapeutic drugs to the cancer cells. Percutaneous biliary drainage. Percutaneous biliary or transhepatic drainage is used to bypass biliary ducts obstructed by liver, pancreatic, or bile duct tumors in patients who have inoperable tumors or are considered poor surgical risks. Under fluoroscopy, a catheter is inserted through the abdominal wall and past the obstruction into the duodenum. Such procedures are used to re-establish biliary drainage, relieve pressure and pain from the buildup of the bile behind the obstruction, and decrease pruritus and jaundice. Targeted drug therapy. Targeted drugs work by interfering with the tumor's ability to generate new blood vessels. They have been shown to slow or stop advanced hepatocellular carcinoma from progressing from a few months longer than with no treatment. More studies are needed to understand how targeted therapies such as the drug sorafenib or Nexavar may be used to control advanced liver cancer. It is also being studied to see if it could help for earlier stage disease. Surgical management. In preparation for surgery, the patient's nutritional, fluid, and general physical status are assessed and efforts are undertaken to ensure the best physical condition possible. Extensive diagnostic studies may be performed. Lobectomy. The removal of a lobe of the liver is the most common surgical procedure for excising a liver tumor. If it is necessary to restrict blood flow from the hepatic artery and a portal vein for longer than 15 minutes, it is likely that hypothermia will be used. For a right liver lobectomy or an extended right lobectomy, including the medial left lobe, a thoracoabdominal incision is used. An extensive abdominal incision is made for a left lobectomy. Tumor ablation for liver cancer. Ablation is a treatment that destroys the tumor without removing it. There are a number of ways to do this. Heating with radio waves. In a procedure called radiofrequency ablation, electric current is used to heat and destroy cancer cells. Using an ultrasound or CT scan as a guide, your surgeon inserts one or more thin needles into a small incision in your abdomen. When the needles reach the tumor, they're heated with an electric current, destroying the cancer cells. Injecting the tumor with alcohol, such as ethanol. During alcohol injection, pure alcohol is injected directly into tumors, either through the skin or during an operation. Alcohol causes the tumor cells to die. Freezing, also known as cryosurgery. This uses extreme cold to destroy cancer cells. During the procedure, your doctor places an instrument called cryoprobe containing liquid nitrogen directly onto liver tumors. Ultrasound images are used to guide the cryoprobe and monitor the freezing of the cells. Liver transplantation. Removing the liver and replacing it with a healthy donor organ is another way to treat liver cancer. Transplant is usually only an option for patients with 1 to 3 small tumors that cannot be totally removed, either because of where they are found or because their liver function is poor. Management. Monitor the patient for fluid retention and ascites. Monitor respiratory function. Turn the patient frequently and keep his skin clean to prevent pressure ulcers. To increase venous return and prevent edema, elate the patient's legs whenever possible. Nurse assesses the patient's physical and psychological status, adequacy of pain relief, nutritional status, and presence of symptoms indicating complications of treatment or progression of disease. Nurse assesses the function of the chemotherapy pump, the infusion site, and the biliary drainage system if indicated. The nurse collaborates with the other members of the healthcare team, the patient, and the family to ensure effective pain management and to manage potential problems which include weakness, pruritus, inadequate dietary intake, jaundice, and symptoms associated with metastasis to other sites. Explain the treatments to the patient and his family, including adverse reactions the patient may experience. For the surgical patient, support, explanation, and encouragement are provided to help the patient prepare psychologically for the surgery. Metabolic abnormalities require careful attention. A constant infusion of 10% glucose may be required in the first 48 hours to prevent a precipitous fall in the blood glucose level that results from decreased gluconeogenesis. Because extensive blood loss may occur as well, the patient receives infusions of blood and IV fluids. The patient requires constant close monitoring and care for the first 2 to 3 days, similar to post-surgical abdominal and thoracic nursing care. The nurse instructs the patient to recognize and report the potential complications and side effects of the chemotherapy and the desirable and undesirable effects of the specific chemotherapy regimen. The nurse also emphasizes the importance of follow-up visits to assess the patient and the tumor's response to chemotherapy and radiation therapy. In addition, the patient is receiving chemotherapy on an outpatient basis. The nurse explains the patient's and family's role in managing the chemotherapy infusion and in assessing the infusion or insertion site. The nurse encourages the patient to resume routine activities as soon as possible, while cautioning about activities that may damage the infusion pump or site. The family, as well as the patient at home with a biliary drainage system in place, typically fear that the catheter will become dislodged. Reassurance and instruction can help reduce their fear that the catheter will fall out easily. The patient and family also require instruction on catheter care. The family and the patient need to learn how to keep the catheter site clean and dry and how to assess the catheter and its insertion site. Patients with implantable ports are instructed about the chemotherapy regimen, types of medications, and side effects that may occur, and appropriate management strategies if problems occur. If a hepatic artery port is inserted from intermittent chemotherapy, patients and their families are provided the same educational content. The patient is instructed to assess the port site between infusions and to note and report any signs of infection or inflammation.